At the outset, I would like to thank Krishnaveni ma'am and the distinguished OBGY team at Yashoda Hospital, High-Tech City for this wonderful opportunity to share this topic of such critical importance. I had been practicing in Hyderabad for last 13, 14 years, and this must be my second or third chance to interact with the most beautiful, elegant OBGY colleagues across the region. So, Krishnaveni madam has delivered a fantastic talk. We all know obstetricians deliver miracles every day for all complex OBGY cases. But as a hematologist, I had to check if the platelets and hemoglobin has signed the approval note. And guess what? I had 15 minutes to convince you why that matters most. So, hematology per se is a specialty. It's a wonderful amalgamation of integration of the art of clinical evaluation integrated with the science of lab evaluation. And obstetric hematology per se is a very interesting and a very exciting topic, and lot of things are happening in this arena. I will share some of the case scenarios and how together as a teamwork we can really bring out very rewarding, gratifying success stories across these difficult to treat obstetric cases. Now, when we think of hematology, again, as I mentioned, many a times the diagnosis is straightforward, but most of the times there are a lot of controversy, and you really need to wear the shoes of Sherlock Holmes to dig out the mystery puzzle underlying each case. So the objective of my presentation is understand the physiological changes, hematological changes in pregnancy, and compare with pathological spectrum, and the distinction between particularly the second commonest hematological abnormality, thrombocytopenia, how simple clinical tools can distinguish us between benign versus critical hematological issues. Recognize life-threatening thrombotic microangiopathies like TTP help. I'm sure a typical HUS might have been covered by our mentor Rajshekar Chakravarti sir. Know when to call hematologist and when can be done when you do, and learn how timely teamwork can turn this panic into a precision medicine with very rewarding outcomes. We all know hematology issues are common in obstetrics, almost 50%, ranging from mild to life-threatening, but only 3 to 4% of these hematological issues are critical, need a very careful collaborative evaluation. Now, these are the physiological changes during pregnancy. Plasma volume is up by 50%, leading to dilutional anemia. There is physiological thrombocytopenia up to 1 lakh at near term, and also there are abnormalities in the coagulation cascade. Pregnancy is a prothrombotic state with upgrading or up-regulating of prothrombotic factors and downgrading of antithrombotic factors. And this is a very nice curve you can see published in NEJM 2018. The platelet count 1.5 to 4.5 first trimester, it can be as low as 1.2, 1.3, and near term, even 1 lakh can be considered normal. So my talk today is I'm going to discuss issues pertaining to platelets and coagulation cascade. So changing gears further, just to kickstart our presentation on thrombocytopenia, audience knowledge check. In pregnant patients with thrombocytopenia, which simple tool investigation can help you distinguish between benign versus critical thrombocytopenia? Ultrasound abdomen to check the spleen size, bone marrow studies, LDH, and past medical history. Anybody across this august audience? Anybody? Any clue? It's LDH. So I will, discuss in detail later. So the 3 cases, play of platelets in pregnancy. This is case number 1, 26 years, primey, 14 weeks gestation, first trimester, incidentally detected severe thrombocytopenia, platelet 36,000, WBC, hemoglobin normal, no significant past medical history. Case 2 is a 25-year G2P1L1, near-term pregnancy, 36 weeks. Again, mild thrombocytopenia, asymptomatic with almost normal hemoglobin and WBC. And to confirm the picture, she has a history of lupus, which is inactive, diagnosed 5 years back. And she is not on any treatment for that, and her lupus is inactive. So case scenario 3, 32-year lady, G2P1, 32 weeks pregnancy, severe thrombocytopenia, platelet 45,000, moderate anemia, and she also had a history of preeclampsia starting at 28 weeks, being managed conservatively with medically, and she started complaint of right upper abdominal quantum pain. So thrombocytopenia in pregnancy, as I mentioned earlier, third trimester platelet count of 1.1, 1 lakh is normal, seen in approximately 7 to 15% pregnancies, and about 1 to 2% pregnancies are affected by severe thrombocytopenia. Now approach, of course, related to pregnancy as well as whether it is a pre-existent or pregnancy-related thrombocytopenia. This is in nutshell. The good news across thrombocytopenia spectrum in pregnancy is 3/4 are benign gestational thrombocytopenia, more so in second and third trimester. And the third trimester severe thrombocytopenia, again alarm, almost 21% are hypertensive disorders of pregnancy, 4% are ITP. Now, thrombocytopenia can be pregnancy specific like gestational hypertensive disorders like preeclampsia, eclampsia, microangiopathic hemolytic anemia like TTP, HUS, HELP, catastrophic APLA, acute fatty liver of pregnancy, or it can be not related to pregnancy like ITP, drug infection associated, underlying hematological malignancies and autoimmune disorders.